Good morning. Thank you for joining us for this webinar presentation today on the clinical and radiographic evaluation of bone lesions. Special thanks to Dr. Karen Agarwal Harding and Harvard Global Orthopedics for inviting me to speak today on this topic. My name is Dipak Ramkumar, and I am the orthopedic tumor surgeon at Leahy Hospital and Medical Center in Burlington, Massachusetts, which is a suburb just outside of Boston. I was asked to present a quick primer and guide to working up new bone lesions and help define a framework for recognizing malignant and concerning lesions from those that are more likely to be benign. In addition, I was also asked to speak a little bit about diagnosis and staging to help all of you that are participating in this webinar to help expeditiously diagnose and treat bone tumors to the appropriate extent. So without further ado, we'll go ahead and get started. Just off the bat, I will state that I really have no relevant financial interests or relationships to disclose. I may discuss the use of certain implants that have been provided a one-time expanded access or compassionate use approval from the Food and Drug Administration, but I will try and limit the entire discussion to on-label treatment for drugs if we end up discussing any of those. So the main objectives of the talk today are to discuss the evaluation of solitary lesions of bone of both benign and malignant etiology. I want to review a systematic approach to the evaluation of radiographs for new bone lesions and help develop differential diagnosis for both benign and malignant entities. We will also understand the characteristic features of malignant and benign lesions on radiographs and distinguish between them. And we will understand the indications for referral to an orthopedic oncology team, including warning signs in the history, physical examination, or on the radiographic and imaging findings. So just to start off, bone lesions, as we all know, can represent either malignant or benign etiologies. By and far, benign etiologies are significantly more common, almost 100-fold more common than malignant etiologies, especially in the pediatric and adolescent populations. Using a systematic approach to evaluating radiographs and lesions can help diagnose more efficiently these bone lesions and minimize invasive and expensive, potentially harmful diagnostic tests and associated unnecessary healthcare costs. So really, the evaluation of any of these lesions should begin with a clinical evaluation, and that really requires a thorough history, physical examination, and examination of the initial presenting radiographs. There are some elements in the different components of this evaluation that could really help narrow down the differential diagnosis for some of these lesions. For instance, in the history, the most important factor is age. There are certain lesions that have predilections for certain age groups, and and having an understanding of those can really help narrow down the differential quickly. So for instance, in the first decade of life, the most common lesions that we see are osteofibrous dysplasia and Langerhans cell histiocytosis. In the early second decade of life, we really see mostly benign tumors like osteochondral defects, fibrous dysplasias, osteochondromas, non-ossifying fibromas, fibrous cortical defects, etc. In the mid to late second decade, so late adolescence, that's when we start seeing some of the malignant etiologies like osteosarcoma and Ewing sarcoma. And then there are a certain list of these prototypical, early adolescents, like age 13 or so, lesions that Dr. Mankin has coined as bar mitzvah lesions. And these include chondroblastomas, osteoblastomas, and osteoid osteomas. Generally speaking, in the older patient, over 40 years of age, the most common diagnoses for any new bone lesion, especially lytic lesions, are metastatic disease from another primary origin carcinoma, plasma cell dyscrasias like plasmacytoma or multiple myeloma, and lymphomas. Similarly, in the history, a lot can be obtained from the history of pain itself. Most benign lesions are usually incidentally discovered and are asymptomatic on presentation. Typically, the child has had some other injury, playing a sport or something else, and gets x-rays for one reason or the other, and an incidental note is made of a lesion in that imaged field of view. Most of those usually require no further workup if they're definitively proven to be benign in nature, and that can oftentimes be made with a radiographic diagnosis alone. But then there are certain patterns in the pain history specifically that can be associated with specific tumors. For instance, acute pain or night pain that's often imminently or immediately relieved by use of nonsteroidal anti-inflammatory medications is usually very characteristic for osteoid osteoma. Rapidly progressive pain with a nocturnal component that oftentimes wakes the child up from sleep consistently and is usually not relieved by NSAIDs may be associated with a malignant bone tumor. And similarly, slow onset, dull, non-progressive pain can be associated with benign aggressive lesions like chondroblastomas, chondromyxoid fibromas, or giant cell tumors. In addition, it is important to also look at some of the associated symptoms. Very rarely, presentation of certain tumors can be associated with additional symptoms like type B symptoms. These cluster B symptoms are things like fevers, drenching night sweats, loss of more than 10% body weight in the past 6 months. And those are oftentimes associated with lymphomas, especially, but also metastatic disease. And fevers and chills specifically can also be associated with Ewing sarcoma, or osteomyelitis, both conditions where there's active, ramped up inflammatory phases. Well, moving on with the clinical evaluation, a physical examination is very important. In pediatric patients, it's important to assess their growth parameters, including their height and weight, and where they fall on their appropriate growth charts. Various conditions like multiple hereditary exostosis and Olliers disease can present with short stature. Um, we don't typically do this as orthopedic surgeons, but an HEENT exam, so head, ears, eyes, nose, and throat exam, is also very important because certain conditions and findings that you see on those exams may be associated with specific syndromes and specific bone tumors. So, for instance, when you look into ears and you see signs of chronic or refractory otitis media with scarring of the tympanic membranes, for instance, as shown in that second figure on the right, that could be associated with Langerhans cell histiocytosis. Microacanthia or floating teeth can also represent mandibular involvement with LCH. When focusing specifically on the MSK exam, you want to look for the location and size of the lesions and assess if there's associated bony tenderness or associated bone or joint swelling with deformity. Things like osteofibrous dysplasia or multiple hereditary exostoses oftentimes present with bony deformities that can be captured just on general inspection. You want to always assess the neurovascular function of the limb and ensure that there's no definitive evidence of neurovascular compromise. Typically, benign bone tumors usually do not cause neurovascular compromise, but if they have an aggressive soft tissue component or are compressing extrinsic neurovascular structures, that can oftentimes be seen in very aggressive tumors, including malignant tumors. And so that's something to be important for you to assess and document early on. You also want to see if the lesions are palpable. Most bone lesions are contained within the cortical window of the bone and usually are not on the surface, with the exception of periosteochondromas and osteochondromas. So many times, if you're able to palpate an actual lesion, that may also give you a clue as to the etiology. So on this figure at the top right, you can see an example of a malignant tumor with a fungating soft tissue mass extending through the medial aspect of the knee. Obviously, that looks very concerning and is most likely a malignant bone tumor. Below, you can see some examples of multiple hereditary exostosis with evidence of various joint deformities that you're seeing due to the multiple osteochondromas and enchondromas that could form in that condition. The dermatological examination is an important component as well, as very many syndromes are associated with specific skin manifestations that can often be seen on a skin examination. It's important to make sure that you're looking for things like axillary freckling and looking for skin lesions specifically, because as I mentioned, they may be associated with an underlying syndromic condition that can help elucidate the etiology of the lesion that you're seeing. So for instance, cafe au lait macules are a good example. Cafe au lait macules are these flat patches of skin discoloration that can be seen in and around the torso. They have been associated with two separate conditions, including McCune-Albright syndrome, which is polyostotic fibrous dysplasia with endocrine abnormalities, or Mazebraud syndrome, as well as neurofibromatosis type 1. So there's two specific descriptions for cafe au lait spots, and we tend to characterize these based on some of the states in the United States. So we have one type of lesion, which is called a coast of Maine lesion. But essentially, if you look at the borders of the lesion, it's very jagged and rugged appearing. There are many kind of incoves and outcoves, much like the coast of Maine, as you can see on the map that's shown right next to it. That sort of intricate patterning to the border is usually known as a coast of Maine macule, which is associated with McCune-Albright syndrome, for instance. Whereas a coast of California macule is one that has a more smooth border and smoother coast, and there aren't as many incoves or jaggedness, if you will, to the transition between normal skin and the macule itself. And that smoother transition is referred to a coast of California spot, which is associated with neurofibromatosis type 1. You also want to assess for potential vascular malformations. So vascular malformations can have cutaneous manifestations with multiple endochondromas as seen in Maffucci syndrome. You can also see focal soft tissue masses in the hand, similar to what you see on the bottom right of this slide, with appropriate radiographic correlates, which show significant phlebolytes distributed, small areas of calcification distributed within the soft tissues and around the wrist and hand, as well as the distal forearm. So again, evaluation of these soft tissue lesions may be very helpful in determining the underlying disease condition. The next component is looking at the lymph node exam. You want to check for ipsilateral regional lymphadenopathy. In the lower extremity, check inguinal and popliteal areas. In the upper extremity, check for axillary, epitrochlear, and antecubital areas for lymphadenopathy. Lymphadenopathy is associated with specific conditions. As we all know, lymphomas is a very common example, but can also occur with infection, Ewing sarcoma, and in the upper extremity associated with epithelioid sarcomas. Similarly, skin malignancies like melanomas can also present with significant nodal metastasis, which may represent enlarged lymph nodes in the ipsilateral limb. So once you've done a thorough history and physical examination, the next component is assessment of available imaging studies. And typically that starts with simple plain film radiographs. These are cheap, these are generally easily accessible, and can give you a lot of information about the type of tumor that you're contending with just from orthogonal view assessment. So when you get plain film radiographs, you really want to obtain at least two orthogonal views. So an AP and a lateral is typically what we obtain. Occasionally, when you're looking at joint structures, oblique views can also be helpful. Remember, in orthopedics, the saying is one view is no view. So really having just a single uniplanar view does not give you sufficient information to make an assessment of a three-dimensional structure, which is what most tumors and lesions are. So important to get at least two good orthogonal views. Remember that most non-malignant lesions can be diagnosed with plain film radiographs alone. They have very characteristic patterns that we will discuss in just a second that may help give you a good suspicion for what they are, and ideally, they can be followed just with radiographs alone instead of doing any advanced imaging or invasive testing. Tumors in the axial locations, like tumors of the pelvis and the scapula or the spine, they may require additional advanced imaging since they have too many overlapping structures to adequately characterize just with radiographs alone, but nevertheless, good idea to just start with simple plain film radiographs. Okay, now that we have finished the history and physical examination, let's take a few minutes to go through a primer to evaluate bone lesions on radiographs specifically, and go through a framework to help identify lesions that are of concern, meaning malignant etiology versus those that are benign. So we'll start with going through an approach to lesion analysis, as I call it, which is basically a stepwise approach, asking a few questions about any lesion that you see, and then helping use that to help determine a differential diagnosis. So as I mentioned, you really want to review radiographs in a systematic fashion whenever you're evaluating a new bone lesion. Just like you were taught perhaps in medical school or in residency to look at chest radiographs and the systematic process through which we look at the bones, at the soft tissue spaces, at the cardiac silhouette, etc., to make sure that you're giving a comprehensive evaluation. You want to follow a very systematic approach similar to that when you're looking at extremity x-rays as well to make sure that you don't miss anything. So specifically with respect to tumor analysis, you really want to find out first and foremost, where is the tumor located? Just like in real estate, it's all about location, 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 meaning certain tumors have a predilection for a very specific area in the bone and usually do not occur anywhere else. And as a result, if you see a lesion in that specific area, for instance, the epiphysis versus the metadiaphyseal junction versus the diaphysis, you can really help narrow down the differential diagnosis pretty well. So look and understand what type of bone it is. Is it a long bone or is it a flat bone? Is the lesion specifically located in the epiphysis? Is it in the metaphysis or is it in the diaphysis? And then also look and assess whether it's contained within the medullary space, is it within the cortical space, or is it on the surface of the bone itself? Answering those questions, like I mentioned, can really help determine what type of lesion you're contending with. So the second question you want to ask is, what is the tumor doing to the bone? And this question really helps understand what the matrix of the lesion is. Is the tumor destroying or replacing the existing bone? If so, what is the pattern that you're seeing? And we'll go through this here in a little bit more detail so you can understand more clearly what I'm referring to. The third question is to determine what is the bone doing to the tumor. And this is really a surrogate for assessment of the margin, Is there an associated periosteal or an endosteal reaction? If so, is it well developed? Does it appear sharply defined? What is the type of periosteal reaction? Is there a sclerotic border around the lesion? These types of questions can help determine both the age of the lesion, meaning how long has it been there? Is it something that's new and rapidly progressive, or is it something that the bone has really had the chance to respond to? And knowing that can again help narrow down their differential pretty well. And the last question you want to ask is, are there any specific intrinsic intrinsic characteristics of the lesion that help determine its etiology? So the Lodwick classification system, which is used to help determine the etiologies of potentially lytic lesions, is actually a very helpful framework to better assess and answer these four questions. And so in order to do that, let's just take a look at the classification itself. This has been used extensively to help describe margins, and there are three major types based on the Lodwick classification. There's a type 1 margin, a type 2 margin, and a type 3 margin. Type 1 margins are defined as geographic lesions, and they're further subclassified into subtype A, B, and C. 1A specifically represents geographic lesions with sharply defined margins, and they usually have a sclerotic border, and they're usually intramedullary in location. And when we say geographic lesion, which is the term used in general for a type 1 Lodwick margin, we're talking about a lesion that is perfectly identifiable on the radiograph and completely separate from normal bone all around it. It doesn't coalesce from multiple lesions. It's usually a single solitary lesion with completely normal surrounding bone and a single area of involvement. So going back, type 1A represents a geographic lesion with a sclerotic, sharply demarcated border. Type 1B represents a lesion that is also geographic, but usually does not have a well-defined border or sclerotic border. And type 3, similarly, is a lesion that is geographic again in nature with very poorly defined borders and can be associated with cortical destruction and cortical erosion. So type 1A, type 1B, and 1C, main differences being in A, you have the presence of a sclerotic border. In B, there's no sclerotic border, but still very relatively well defined. And type C, still geographic, but the borders are usually almost invisible and do not necessarily specifically have sclerosis and can be associated with cortical destruction. Type 2 lesions are generally considered moth-eaten lesions, and so these are often geographic borders, but they have very poorly defined margins. There's usually destruction in multiple foci, and there's usually cortical destruction as well. There's oftentimes no associated sclerosis whatsoever. And lastly, the type 3 margins are what we refer to as permeative margins. There's no recognizable margin between lesion and normal bone. They're not geographic. They're usually multiple lesions that are coalescing into one larger area of involvement, if you will. There's permeative destruction, meaning there's no clear distinction between what is tumoral or lesional tissue and what's normal bone. And again, sclerosis is usually always absent in a type 3 margin. So here are some radiographic correlates to the pictorial representation that I just showed you. So on the far left here of the slide, you can see a geographic lesion. It's contained here along the medial aspect of the distal femur. You can see that it's sharply demarcated. There is a clear distinction between what's normal bone and what's lesional tissue, and it's extending from the metaphysis and into the epiphysis of the distal femur. This is a type 1 margin. There is no sclerotic rim here, so it's probably a 1B would be the best way to describe this. Remember, generally type 1 margins are geographic, and they usually represent benign etiologies. In the central picture there, you can see a moth-eaten margin or a type 2 margin. There are scattered and confluent holes in the bone, giving the impression that these are arising from multiple different foci. There's generally associated cortical destruction. And even if the lesion is geographic, there are multiple lesions contained within the bone, which is what separates a type 2 margin from a type 1C margin. And lastly, on the far right of the slide, you can see a permeative margin. You can see a lesion again contained within the distal diaphysis of the femur. Again, no clear differentiation between the normal trabecular pattern and lesional tissue. It's usually indicative of an infiltrative marrow replacing process, and this is a good example of a metastatic carcinoma. And you can also see on the lateral end of the femur there and the distal diaphysis, there is evidence of cortical destruction and lesional tissue that is likely forming a extraosseous soft tissue component. So we've looked at pictorial representations of these margins. We've also looked at radiographic representations. And so now let's correlate those radiographs with gross and histopathology. So you can see at the top left there, this is a type 1A margin. This is actually a non-ossifying fibroma. You can see it's cortically braced and there's a nice sclerotic rim around the entire lesion. If you put your thumb and cover up the lesion, the rest of the bone essentially looks completely normal. That is by definition a geographic lesion. And now when you look at gross pathology of that same lesion from a resection specimen, you can see again that there is this nice, almost cortical bone-like sclerosis formed completely around the lesion, with some thinning of the cortex, of the native cortex right here, and the lesional tissues contained well within that respective boundary, and the rest of the bone looks essentially completely normal. On the right-hand side, again, you can see a zoomed-in view of that non-ossifying fibroma. Again, nice rind of a sclerotic margin. And on histopathology, again, you can see the lesional tissue right here, and then there's fine cortical bone all around it, very similar to what we see on the radiographs, and the lesion is completely separate from the rest of the trabecular patterning of bone. Below, you see a 1B margin. This is a good example, again, of a geographic lesion, but there are no sclerotic borders, as noted. And you can see that the lesion is essentially completely replaced the normal trabecular pattern of the bone in the distal radius. If you correspond that to the underlying section of the histology specimen, you can again see that there is absence of sclerosis. There's no fine, thick rind like we see in this picture up here. And you have the lesional tissue contained within the central portion of that lesion, just like what you would see on the radiographs. Here's another example of a 1B margin. Again, this is seen on the medial aspect of the distal femur. Again, the lesional tissue is right here, still relatively distinct borders, but again, no sclerosis. And then when we look at the photomicrograph, you can again see lesional tissue all contained within the medial extent of the distal femur, normal trabecular bone out here, but again, no sclerosis around the lesion itself. Okay, moving on, these are some examples of type 2 and type 3 margins. So again, on the Lodwig type 2 margin, you can see a lateral radiograph of the distal femur here, where you have almost a moth-eaten appearance with multiple holes that are almost coalescing and confluencing into one single lesion. Again, extensive cortical destruction is seen, and there are still multiple lesions seen throughout the imaged portion of the distal femur, which again corresponds to the histopathology that we're seeing on the left-hand side. On the right here, we have an example of a permeative margin. Examples of these are usually malignant bone tumors, including metastatic disease and osteosarcoma. There's no clear distinction between normal trabecular pattern of bone and lesional tissue. And you can see that the margin is very permeative. There's no clear distinct border like we see even with type 2 margins, again indicating a very infiltrating marrow replacing process. So now that we've had a chance to really review the margins, let's talk a little bit about matrices, which is essentially what is happening within the lesion itself. So matrices or matrix refers to the acellular, intracellular substances produced by the mesenchymal cells that are forming the lesion. And there are different types of matrices that you could see. You could see osseous matrices that are oftentimes shown in bone-producing tumors like osteosarcomas. You could have cartilaginous matrices, which are seen in cartilage-producing tumors like enchondromas or chondrosarcomas. You can also see fibrous or collagenous matrices that are seen in fibrous tumors, and myxomatous matrices, which are seen in myxoid-type tumors. So regardless, based on what the actual appearance of the matrix looks like on radiographs, you can have a better idea of what the differential diagnosis may be of the underlying lesion. So we'll go through some examples here in just a second. So let's take a look at some of those matrices that are being produced in these different radiographs. So the far left of the slide, you can see an example where there's no matrix. It almost looks like just soft tissue seen in the bone with the replacement of the proximal medial aspect of the tibia there. There's really no characteristic appearance, at least radiographically, to the lesional tissue, in which case there's no definitive matrix that's shown. Immediately to the right of that, you can see an example of a fibrous matrix. You can see the lesions here contained within the proximal femur almost have this ground glass-like appearance. This would be very common in fibrous tissue. And what is ground glass? We say this a lot, but here's an example. You could see that opaque portion of the glass that almost looks like it's grit blasted instead of being perfectly translucent. That's what we refer to as ground glass. So it's almost, there's a subtle opacity to this lesion. Does not look completely see-through like you see in the far left, but at the same time does not look like normal bone either. And that refers to a fibrous matrix. Immediately to the right of this image, you can see a lesion contained within the medullary space of the distal femur. It almost has a ring and arc calcification pattern that almost looks like popcorn. And if you see popcorn, you can see the popped corn and the kernel in the center, and there's almost this ring that forms around it. Looks very globular. That's very characteristic of a cartilaginous matrix, and so this is a cartilage-producing tumor, likely an enchondroma. On the far right, you see an example of an osteoblastic matrix or osseous matrix. You can see that there's almost this chalk or cloud-like calcification that's seen, and basically there's a replacement of the normal trabecular pattern with kind of this hard, cloud-like or chalk-like substance, which happens to be bone. And so this is an example of an osteosarcoma. So let's take a look at some of these matrices as we see on radiographs and correlate them to some histopathology and gross pathology. So you could see on the radiograph on the far left there, this is a dense matrix. It looks very cloud-like or chalk-like with a periosteal reaction and likely ossification of that extraosseous soft tissue component, very characteristic of an osseous matrix. And if we look at a photomicrograph of the underlying H&E section, you can see that there is a lot of bone formation, primarily woven bone, even at very low power, kind of these nests of pink areas, suggestive of osteoid formation and calcification. Again, highly suggestive of an underlying osteosarcoma. On the right-hand side of the slide, you can see another osseous matrix that's being produced in the distal femur with a periosteal reaction and ossification of the soft tissue component. And if you look at that under gross view, you can see that there is essentially replacement of the trabecular bone with hard cortical-like bone. These hard white areas right here, again, indicative of an osseous matrix or a bone-producing tumor. Again, this happens to be an osteosarcoma. Here are some correlating examples of a cartilaginous matrix. Again, we see a lesion with this ring and arc calcification pattern seen in the proximal humerus. Again, highly suggestive of a cartilaginous matrix. If you take a look at the photomicrograph and gross section from gross pathology of that lesion, on the inside in the medullary space, you can see kind of these white areas that almost look like cartilage, like hyaline cartilage, interspersed between what is more normal appearing trabecular bone. And when you look at the micrographic section on H&E staining, you can see, again, there's these basophilic areas, essentially consistent with cartilage contained within the medullary space of the bone and the cortical edges of the bone. Again, suggestive of a cartilaginous matrix. Here is an example of a fibrous or fibroosseous matrix. Again, ground glass type appearance on the radiographs. Here, as you can see, contained within the metadiapsial junction of the long bone. Kind of focal areas that are dark, but also have this ground glass appearance. They're not completely translucent or see-through, as you can see in the more zoomed-in version. And what does that look like on gross pathology and photomicrographs? You can see, normal trabecular pattern to bone, and then focal areas where there's bands and bands of collagenous tissue interspersed between the trabeculae, suggestive of a fibroosseous or fibrous fibrous matrix. So the next step, after we have looked at both margins and matrices, is to now assess for a periosteal reaction. The periosteal reaction is essentially a measure of the intensity, aggressiveness, and duration of the inciting process. We usually only see periosteal reactions in rapidly growing tumors where you have elevation of the overlying periosteum of the bone due to rapid expansion of lesional tissue. So they're oftentimes a hallmark indicator of an underlying malignant tumor, since the lesional tissue is expanding so rapidly and the bone has not had time to accommodate for that rapid growth. The extent and degree of the periosteal reaction really vary with the location of the lesion, and there are very many configurations and patterns that we see of types of different periosteal reaction. As I mentioned, the configuration itself relates to the manner and time course of the production, and new bone formation depends on degree of periosteal elevation and activity of the stimulating process. So generally, we classify periosteal reactions into three main categories, and they include continuous, interrupted, and complex. So one of the most common periosteal reactions that we see is the Codman triangle. This was named after Ernest Amory Codman, and it refers to the little cup of reactive bone that's almost trumpet-shaped, which surrounds the upper limit of the tumor and appears on the X-ray as a triangular space. So imagine you have an underlying tumor that's rapidly growing, rapidly pushing through the cortical bone and causing elevation of that thick periosteum on the surface of the bone. And where that periosteum joins back to the surface of the cortex and the start of that elevation occurs, you form this kind of triangular shape or triangular window, and that's referred to as a Codman's triangle. So here are some pictorial representations of the various types of periosteal reactions that we see. As you may recall from before, we talked about either interrupted or continuous patterns of periosteal reaction, and they can oftentimes take multiple different shapes and configurations, including onion skinning, which is very characteristically associated with Ewing sarcoma, but can also have a spiculated or hair-on-end appearance or a sunburst pattern, like you see in the bottom. Again, can be associated with multiple malignant bone tumors, and again represent this rapid elevation of the periosteum in the setting of a rapidly expanding lesion. So here are some radiographic examples of the various patterns of periosteal reactions that we see. So on the left-hand side of the slide, you can see what I refer to as a Codman's triangle, essentially the elevation of the periosteum and the point where the periosteum essentially confluences with the normal periosteum in the cortical surface of the bone, and the upper extent of the tumor is where you form that triangular shape of elevation, as you can see here in the anterior cortex and here in the posterior cortex. It's essentially referring to the lifting of the periosteum in response to rapid tumor growth, and is more apparent in pediatric patients because they generally have thicker periosteums than adults. So here is an example of onion skinning that you see, here you can basically see multiple layers almost in the periosteum itself with the elevated periosteum. This is very commonly seen in Ewing sarcoma. Oftentimes, this has to do with the rapid expansion of tumor through the eversion systems and the canaliculi in the bone itself. They egress through these eversion systems into the soft tissue space, elevate the periosteum. Eventually, due to ebbs and flows in tumor growth, as the tumor itself outstrips the underlying blood and nutritional supply, there's periods of kind of slower growth or cessation of growth, which then leads to calcification. And then as the angiogenic factors from the tumor get released and growth recurs at a very high rate, you get progressive elevation. So this is almost like rings on a tree. When you cut the tree down, you can see periods of growth of the tree based on those rings, and the age of the tree can be determined. It's a very good example of how onion skinning actually occurs, where you have these periods of calcification that occur during senescence or slowed tumor growth, and then a rapid expansion of the periosteum that occurs after restoration of the nutritional blood supply to the tumor, forming this periodic calcification pattern or onion skinning pattern that we see in the periosteum itself. On the far right there, you can see a hair-on-end or sunburst pattern periosteal reaction. Again, this occurs with rapid growth. Those actual sunbursts or hair-on-ends that you're seeing are the Sharpie's fibers that are being elevated. These Sharpie's fibers normally attach the periosteum to the cortical surface of the bone, but they're being rapidly expanded and essentially tethering the periosteum to the cortical surface of the bone because of underlying tumor that's pushing the periosteum up off of the cortical surface of the bone. Again, hallmark signs of a malignant, rapidly growing tumor. So now that we've gone through this primer, basically what I want you to understand and take away from that portion of the talk is that solitary bone lesions can range from completely benign entities to floridly malignant high-grade tumors. The lesion characteristics often appreciated on plain film radiographs can help provide a differential diagnosis and really help narrow down the differential that you're contending with. A systematic approach to understanding and evaluating these lesions really involves assessment of the margin, which is what is the bone doing to the tumor, the matrix, which is what is the tumor doing to the bone, and the presence or absence of periosteal reactions, which when present usually are indicative of an underlying aggressive, rapidly growing and malignant process. And using the combination of these three elements, you can really help narrow down the differential. Here is a summary slide that looks at the various characteristics that we just went through and whether it's a malignant or underlying non-malignant lesion. We can kind of go through this table rather quickly. Remember, for borders of the lesion in malignant or aggressive neoplasms, The borders are usually poorly defined because, again, the bone has not really had time to react to the rapid growth of the lesional tissue, whereas in non-malignant conditions, they're usually well defined or have a nice sclerotic border because, again, there's a sharp zone of transition between normal and abnormal bone because the bone has had time to adapt to that lesion. When you see a periosteal reaction, especially one that's spiculated, interrupted, or with a Codman's triangle, that's usually indicative of a malignant or aggressive process, whereas non-malignant conditions or benign conditions don't usually produce a periosteal reaction. Cortical destruction, again, is usually seen in malignant processes. Sometimes they have a moth-eaten appearance, much like the type 2 Lodwick classification that we had discussed previously, or they can have a permeative pattern where there's a very widened zone, if you will, of transition between normal and abnormal bone, again occurring because the process underlying the formation of that lesion is infiltrating and not clearly delineated and defined as you would see in a more geographic type lesion. Remember, that's usually a hallmark of a malignant process because in most benign processes, unless it's a benign aggressive condition, you usually do not see cortical destruction. And lastly, soft tissue extension, again, for the reasons that we described above, malignant or aggressive tumors can really produce soft tissue masses because they rapidly grow out through the eversion systems and essentially lead to unabated tumor growth outside of the bone. That can then cause elevation of the periosteum. And that's really a hallmark of malignant tumors, whereas usually benign tumors really are confined by the natural barriers of the bone, like either growth plates or cortical bone, and they do not extend into the soft tissues. So with that now being said and done, let's go through some case examples. And I usually try to do this as a game where we have an interactive audience. But since this is a webinar, I will just imagine that you guys are responding appropriately to each question. But we'll go through this game of benign or malignant, which is based on the classic American TV show called Deal or No Deal. And so we'll just go through some examples to help use exactly what you just learned in that primer and apply it directly to some case examples. So here's the first case. This is a 50-year-old female with a left lower leg lesion presented with progressive left lower leg pain and difficulty weight bearing. And as you can see on these radiographs, it's an AP and lateral view. We want two orthogonal views. You can see that there's a permeative lesion seen on the bottom portion here of the image in the distal diaphysis of the tibia, eroding through the medial cortex. And while it is somewhat geographic, there's no clear border between lesional tissue and normal bone. It has a very permeative margin. If we look at an MRI scan, so here are coronal sections as well as sagittal sections. You can see that there's a lesion that's iso-intense to skeletal muscle, maybe slightly hypo-intense to skeletal muscle on T1 weighted images. Clearly, there's loss of the medial cortical margin there with a large extraosseous soft tissue component extending into the medial soft tissues. And similarly, also there is loss of the anterior and posterior compartments, cortices as well, with significant marrow replacement by tumor. So this patient ultimately ended up having a metastatic lung adenocarcinoma, clearly had multiple features on the x-ray that were suggestive of an aggressive process with a permeative margin, cortical destruction, extraosseous soft tissue component. All of those are characteristics of malignant processes. And given her age of 50 years old, the most likely conditions could be either metastatic carcinoma, multiple myeloma, or lymphoma. And ultimately, she was diagnosed with metastatic lung adenocarcinoma. So bone metastases are usually diaphyseal in location, but can also be metaphyseal or epiphyseal. We usually see them in the adult population, usually over the age of 40, and oftentimes present with progressive pain or even a pathological fracture. The margins are permeative, as we just described. The matrix can be variable depending on if it's a lytic process or a blastic process, and the periosteal reactions can also be variable depending on rapidity of tumor growth as well as elevation of that periosteum. Treatment usually involves a combination of observation versus external beam radiation, and if painful or at risk for pathological fracture, some form of prophylactic stabilization with local control, and may also include resection and reconstruction depending on the type of lesion it is, and the whether it's oligometastatic or truly widely metastatic, and multiple other factors that kind of go into that decision making, which are really outside the scope of this talk. So next case here is a 14-year-old young male with a left ankle injury. was playing football and twisted his ankle and started experiencing some ankle pain and was noted to have these radiographs. Again, AP and lateral view. Benign or malignant? Good job, it's benign. As you can see, there is a sclerotic border. It's a geographic lesion. There's no significant cortical destruction. The matrix kind of looks like it's ground glass. It's not truly translucent and see-through. It's not truly chalk-like or cloud-like, representing an osseous matrix, and it certainly does not look like a cartilaginous matrix. And so this lesion, eccentrically located, more cortically based, is a non-ossifying fibroma. So non-ossifying fibromas are usually metaphyseal. They occur in the distal femur or distal tibia, sometimes in the proximal tibia as well. They're eccentrically located, as mentioned. The typical age group that we see them in is in teenagers, and it's usually an incidental finding, like in this patient who had a twisting injury while playing a sport and ultimately had x-rays obtained that revealed an incidental finding. The margin is geographic. You can cover up that lesion and the rest of that bone looks completely normal. The matrix was fibrous, ground glass in appearance, and there's no associated periosteal reaction. So the treatment for these lesions is usually observation. If it's significantly painful or there's a risk of pathological fracture, you can curettage and allograft pack the lesion. So when is a non-ossifying fibroma not a non-ossifying fibroma? And so these are red herrings that you should be aware of. So here is an example. So this is a 19-year-old young lady that presented with knee pain. And these were her presenting radiographs. Again, remember, one view is no view. You really should look for orthogonal views, but I did have just AP views that I wanted to show you, and you can see the lesion here contained within the medial aspect of the proximal tibia. Again, what appears to be a pretty sclerotic geographic lesion, sclerotic margin, but if you look at her MRI scan, you can see that there is significant marrow replacement in the upper part of the tibia. There's almost complete destruction of the medial cortex. And when you look at the sagittal view, you can see that there's a large soft tissue component as well, highly suggestive of an underlying malignant lesion. And so she ultimately underwent a biopsy and was found to have a high-grade osteosarcoma. And so was treated with a resection and proximal tibial replacement. So osteosarcomas, they can be metaphyseal or epiphyseal in location. Very rarely are they diaphyseal. Usually we see them in the first and second decades of life and are associated with periods of accelerated linear growth, like that teenage growth spurt. The margins are very permeative. There's no clear distinction between lesional tissue and normal trabecular bone because there's aggressive marrow replacement that's occurring, and the matrix is usually osseous or bone forming. The periosteal reactions are often present, like a Codman's triangle, and the treatment is usually neoadjuvant chemotherapy with wide or radical resection and reconstruction with adjuvant chemotherapy. So here's the next case. This is a 26-year-old gentleman who presented with right forearm pain. As you can see, there's a lesion there in the proximal radius. Is this benign or malignant? I will give you some additional MRI scans as well. You can see that there is some marrow replacement that's occurring in the proximal radius, and significant loss of the trabecular pattern, significant loss of the cortical structure as well, with extraosseous soft tissue components seen on all of these views. And ultimately, this patient had something called a desmoplastic fibroma. You would not be wrong to be worried about this lesion and think this was malignant, but this was ultimately biopsy proven to be a benign but aggressive condition called a desmoplastic fibroma. And he actually underwent allograft resection and subsequent, he underwent resection and subsequent allograft reconstruction with a plate screw construct, as you can see here, and ultimately had a good functional result. So desmoplastic fibromas can be diaphyseal or metaphyseal in location. They present in a variable age, but typically in the second or third decade of life. So usually late teens to 20s, sometimes into the 30s. Margins are geographic. Again, you saw that lesion was perfectly contained to the proximal radius. The matrix itself is fibrous, ground glass in appearance, and there's usually no periosteal reaction. In this case, we really did not have a periosteal reaction, but there was significant expansion of the bone in the area of the lesion, which is probably what is suggestive of it being more of a benign process than truly a malignant process. The treatment usually involves curettage and grafting or marginal resection, reconstruction. If it's not painful, then you can also observe. So next case is a 10-year-old male who presented with right knee pain. Again, you can see almost a geographic lesion contained within the medial proximal tibia. It's in the metaphysis. It doesn't appear to involve the epiphysis, and there does appear to maybe be some loss of cortical contour both medially and anteriorly. Benign or malignant? Well, let me give you some additional imaging. You can see on an MRI scan both axial and sagittal views. What is immediately apparent is these fluid levels where you have kind of areas of hyperintense signal on these fluid sensitive sequences and areas of more hypointense signal almost layered out. And this is pathognomonic and characteristic for something called an aneurysmal bone cyst. But aneurysmal bone cysts can oftentimes present in a very similar fashion to telangiectatic osteosarcomas, so you have to be careful there. Certainly, based on the original radiographs, this was quite concerning and not unusual for a benign but aggressive lesion like an aneurysmal bone cyst. So, aneurysmal bone cysts are usually epiphyseal or metaphyseal in location. They tend to occur in adolescence. They're very geographic and they have an eggshell sclerotic rim, almost a soap bubble appearance. There's usually no matrix, like we saw, it was almost translucent, and usually no periosteal reaction. And so, treatment usually is, if symptomatic, they usually are treated with sclerotherapy, or if the lesion is quite large, they can undergo curettage and bone grafting with possible plate fixation if necessary or at high risk for pathological fracture. All right, here's another case. This is a 20-year-old gentleman who presented with lower leg pain. These are AP and lateral radiographs. Again, you can see in the diaphysis of the tibia, there is this focal area where there does appear to be some cortical expansion. It's seen primarily medially on the AP radiograph and slightly posteriorly on the lateral radiograph. And this patient had a bone scan also completed, and as you can see, there's intense uptake seen within the area of the lesion. So, benign or malignant? If you guessed benign, you are right. This is an osteoid osteoma. And so osteoid osteomas, they can be diaphyseal or metaphyseal in location. They're usually cortically based, and they occur in adolescence, somewhere between 10 and 20 years of age. They have a thick sclerotic margin with usually a central nidus that's oftentimes only picked up on advanced imaging like a CT scan. There's usually no matrix, but do look for that area of translucency representing the nidus. There's usually no associated periosteal reaction, and treatment for this is usually observation. If symptomatic, they can be treated with radiofrequency ablation or for larger lesions, curettage and grafting. So again, going back to the same principles that we learned in our primer, this was, again, not a destructive lesion. It was cortically based. There's thickened margins, thickened sclerosis around the lesion itself, and no aggressive features like a periosteal reaction, probably benign in nature, despite the fact that the patient was having pain. So this is another case. This is a 80-year-old female who presented with low back pain, ultimately worked up with a CT scan by her primary care physician, and was found to have this lesion contained in the sacral ala. So benign or malignant? You can see that the cortices of that portion of the ala are well preserved. The lesion appears to be somewhat geographic. There is a well-defined border between the area of lesional concern, kind of this lucency that you're seeing right here, as well as the normal trabecular pattern of the bone. All of that should point you towards something that's more benign in nature. And if you look at the bone window specifically, this highlights the margins a lot better. You can see that the cortical bone is really well preserved, but there is this focal area that seems a little bit more void of trabecular bone, which is different from the contralateral side, but also the contralateral side seems a little devoid of trabecular bone. And so if you thought this was benign, you're absolutely right. This is severe osteopenia or marrow replacement that tends to occur in older patients. This is a good chart for you to remember for CT scans that looks at attenuation of various tissue types. And just remember that bone has the highest attenuation at 1,000 Hounsfield units, and air has the lowest attenuation at minus 1,000 Hounsfield units, and everything else is somewhere in between. And so if you have the ability to measure the actual attenuation of that area, you would see that it was probably in the range of fat, somewhere between minus 30 to minus 70, which is highly indicative of osteopenia or underlying fatty replacement of the trabecular architecture associated with osteoporosis and bone loss. So here's another case. This is a 17-year-old gentleman who presented with left knee pain. On the AP and lateral radiographs, you can see there is a surface lesion contained within the medial soft tissues of the distal femur, almost a pedunculated appearance, and there is continuity of the medullary cavity between the medullary space of the host bone and the lesion. You can see that the cortex actually comes up and around and doesn't just appear to continue straight through the stalk of that lesion. So benign or malignant? You guys guess benign, you're absolutely right. This is an osteochondroma. This is a pedunculated osteochondroma. So these are usually, they occur in the diaphysis or metaphyseal regions. They're cortically based. They tend to be first noted in adolescence, though can present in adulthood as well, likely in a lesion that was completely asymptomatic but was never picked up or caught on as an incidental finding on imaging. The hallmark of this lesion is that there's medullary continuity of the lesion itself, and the lesion can be either pedunculated or sessile. So as I showed you before, the medullary trabecular pattern continues into the stalk of the lesion, which is again a hallmark of this type of benign tumor. The matrix, usually there is a cartilaginous cap, especially in the adolescent population, and you can better appreciate that on an MRI scan. There's no associated periosteal reactions, and usually because of the benign nature, if the patient is asymptomatic, you can simply observe. If they're symptomatic, then you can excise. So again, another red herring. When is an osteochondroma not an osteochondroma? So here's an example of a patient. It is a 17-year-old gentleman who presented with left knee pain. You can see on the lateral radiograph, there's this cloud-like calcification pattern, chalk-like calcification pattern seen in the posterior soft tissues with a focal periosteal reaction, or at least periosteal elevation. If you look at the axial cut of the T1 weighted MRI scan, you can see that there is a focal area of cortical loss in the posterior femur with a soft tissue component that seems to be extending out from there. And so even though this looks like a possible osteochondroma, it really is not. Here's another example with a much larger, more broad-based area of involvement extending through the entire posterior cortex of the femur with significant ossification, significant cloud-like matrix that you're seeing, consistent with bone being the underlying matrix. And ultimately, this patient was diagnosed with an intermediate grade paraosteal osteosarcoma and underwent a hemicortical resection with reconstruction using a allograft and did quite well. So with those few case examples, hopefully the distinction between benign and malignant is a little bit more clear. Again, this is not something that I expect you guys to be completely familiar with after just one lecture, but with ongoing practice, you'll be able to pick up patterns and using that same framework that we discussed, help identify factors that are highly concerning for a potential malignancy versus not. So just in summary, solitary bone lesions can really range from completely benign entities to floridly malignant high-grade tumors. The lesional characteristics, which are often seen best on a plain film radiograph, can really help provide the differential diagnosis. And when you combine the lesional characteristics with historical elements, including age, lesional location, and symptoms, you can really come down with a very narrow differential that may help identify what the underlying malignancy is prior to even going down the pathway of a biopsy. So remember, when you're looking at radiographs, that you take a systematic approach to assessing the lesion, and you want to assess the margin, the matrix, and the presence or absence of a periosteal reaction. And doing those three things consistently, you can really help identify the potential underlying histological underpinning of the process and help ensure that this patient gets the appropriate care. So with that being said, let's move on to discuss an illustrative case. I really wanted to use this case as a way to not only help potentially diagnose the lesion based on x-rays and imaging, but then also go through the workup of this lesion, including potential biopsy and appropriate staging and subsequent treatment. So this is a patient that I took care of as a 63-year-old female who presented with a progressive painful left lower leg mass and pain with weight bearing. The mass was noted almost 4 months prior and had progressive interval enlargement. She does have a history of rheumatoid arthritis, and initially the patient thought this was related to rheumatoid arthritis and was potentially a rheumatoid nodule, but this was not really adjacent to any joint. She initially saw her primary care physician and was ultimately referred to rheumatology. Rheumatology sent the patient back to the primary care physician, and she was then referred to plastic surgery. The plastic surgery team saw her and recommended a biopsy, but stated that the patient would need to seek care with an oncological surgeon since this was outside their scope, and she ultimately returned back to her PCP and had subsequent imaging studies that were obtained. So here are the radiographs, both AP and lateral. This case might be familiar to you since we did look at these images just a little while ago. As you can see in the distal third of the diaphysis of the left tibia, there is a focal lesion with a very permeative margin with some suspicion of possible medial cortical loss and posterior cortical loss, highly concerning for an underlying malignancy. So applying the principles that we discussed earlier, given the patient's age, 63, and demographics as well as location of the lesion, we can really help help develop a differential diagnosis. So I think you guys would all say that this is probably aggressive given the extent of the cortical loss, the permeative margin, and the progressive pain that the patient is experiencing. And so in patients that are aged over 40 or 50, the most common diagnoses for an underlying bone lesion really is number 1, 2, and 3, metastatic disease. By and far, metastatic disease is the most common etiology for an aggressive appearing bone lesion. Next is myeloma or plasma cell dyscrasia, and lastly is lymphoma. So based on that, I think we would all agree that this is highly concerning for underlying metastatic disease. And remember, there are certain primary carcinomas that have a predilection to metastasize to bone. The most common of those are breast, lung, thyroid cancer, kidney cancer, and prostate cancer. And the spine is usually the most common site of bone metastasis, but the long bones, including the femurs and humeri, are also very, very common and can be associated with significant morbidity and mortality. So again, let's look at a few of these photomicrographs just to go through some of the same concepts that we reviewed in our primer. As I mentioned before, lesions from metastatic disease can be either blastic or lytic in nature. Generally, the most common lesions that are purely blastic are prostate cancer, though some GI malignancies can also present with blastic mets, and lung and breast cancer can sometimes present with mixed blastic-lytic mets. So lytic metastases are usually seen with lung cancer, thyroid cancer, melanoma, multiple myeloma, and renal cell carcinoma. And as I mentioned, mixed blastic lytic lesions can be seen with lung and breast cancer. So here are some examples. You can see on the top left of the slide, there's a focal blastic lesion seen in the intratrochanteric region of the right femur. And this patient, as you can see on the gross pathology, clearly there's abundant bone formation in and around the area of concern, highly suggestive of a bone-producing tumor, in this case, metastatic prostate cancer. On the bottom left of the slide, you can see a focal lytic lesion seen on a CT scan with cortical interruption and an extraosseous soft tissue component. And there's the gross pathology of that same lesion. Again, you have normal trabecular bone, almost as clear, distinct margin between lesional tissue and bone, with loss of the cortex here and a large soft tissue component that has formed, completely replacing the marrow elements on this aspect of the bone. So, given the mass that we were seeing on physical examination and the presence of a permeative lesion, we proceeded to obtaining advanced imaging just to get a better sense, since this was a new diagnosis and the patient had not formally received a diagnosis yet. So we got an MRI scan, and these are coronal and sagittal T1 weighted images. You can see again that there is significant marrow replacement over the central portion of the diaphysis of the tibia, with loss of the medial cortex and a large soft tissue component that has then developed. The actual lesional tissue appears to be iso-intense to maybe slightly hypo-intense when compared to skeletal muscle, and appears to be well defined. I mean, it's certainly infiltrating, but you can see that there is clearly a distinct border between lesion and normal marrow elements. And this is better accentuated also on the sagittal views, where, again, the posterior cortex seems to be somewhat lost by this destructive and aggressive process. So based on both the x-rays, the history, as well as the MRI scan, what do we think? Is this malignant or benign? And I think all of you are really thinking that this is malignant, and if so, you're absolutely right. This has some hallmark characteristics and highly aggressive characteristics, including cortical destruction, relatively rapid growth, extraosseous soft tissue component, all of which are suggestive of an underlying aggressive process. And so you're absolutely right that this is probably malignant in nature. And as we discussed before, the diagnosis of a new bone lesion really involves a thorough history and physical examination with plain film radiographs of the entire compartment, which we obtained tibia and fibula films of the left side, both AP and lateral. In the spine, if you do see a lesion like this, remember that you need to ensure that the entire spine is appropriately imaged. So usually a lesion, say in the cervical or thoracic or lumbar spine, oftentimes necessitates imaging of the entire spine to ensure that this is not a multi-level process. So advanced cross-sectional imaging can be helpful, as in this case, depending on the appearance of the lesions on the radiographs and suspicion for soft tissue extension. It's really helpful sometimes to get the advanced imaging like an MRI scan, mainly to ensure that it isn't multifocally involved in the bone itself. And in a situation where you're considering a primary bone malignancy in the differential, it's important to help establish that and help plan your biopsy. In metastatic disease, labs can also be obtained. There is some degree of controversy on the utility of these labs, but certainly the textbook answer is a set of labs, which we will go through in a second here. And lastly, definitive histopathological confirmation via biopsy. So let's look at some of the labs that we obtain. So this is a famous paper that was put out by Dr. Rugraf and Dr. Simon in Chicago. This was published in JBJS, and this essentially looked at what specific labs may be very helpful in ascertaining the diagnosis in a patient with suspected malignancy in adulthood. And so the most common labs that we obtained are CBC with differential, a comprehensive metabolic panel, which essentially includes a standard chemistry and electrolyte panel with addition of liver function tests. We also check the LDH level. We check the bone-specific alkaline phosphatase level. We check the ESR and CRP, which are inflammatory markers and non-specific, but can help, distinguish between a process like, say, osteomyelitis and potentially a malignancy. We also check serum protein electrophoresis with immunofixation, urine protein electrophoresis, as well as quantitative immunoglobulins in a serum-free light chain assay. And what these are looking for are essentially paraproteins that we see in plasma cell dyscrasias like multiple myeloma. And I'll highlight a case where that serum-free light chain really helped make the diagnosis prior to biopsy. We also check TSH with reflex T4, which just means that the TSH is elevated. We check a T4 level as well as a PSA level in males. So in combination with radiographs and cross-sectional imaging, usually a CT of the chest abdomen pelvis, these labs helped achieve a diagnosis in more than 85% of cases as presented in this series. So as promised, let's just take a quick aside to look at some of the issues on light chains. So remember, intact immunoglobulins basically have both a heavy chain and light chain component, and 80% of myeloma cases really present with intact immunoglobulins. There are, however, cases of multiple myeloma that can present with a free light chain prominent disease. And the free light chains are really known as the Bence-Jones proteins. And this occurs in 20% of all myeloma cases where they only make light chains. And this is often associated with renal failure, which is a part of the CRAB criteria that we use to diagnose multiple myeloma. And so in patients that really have renal insufficiency, so creatinine more than 2 milligrams per deciliter, and really no other clear explanation, you want to make sure that you assess the free light chain assay to make sure that they don't have Bence-Jones proteins, because they may not have an M spike on a standard SPEP or UPEP, and this may help make the diagnosis of a multiple myeloma. So remember that serum-free light chains are usually present physiologically, but the ratio is rapidly changed and massively expanded in patients with a light chain myeloma. And the majority of majority of patients with multiple myeloma will have some amount of free light chains noted. So let's just take a quick look again at the plasma cell or clonal expansion of plasma cells that we see in multiple myeloma. Again, remember that immunoglobulins have both heavy chain and light chains, and so normally the light chains are bound to the heavy chains, and this is the M spike that you see as this prototypical increase in clonal expansion of a single type of immunoglobulin. In a light chain heavy myeloma, however, you have significant production or overproduction of the light chain component as well, which then forms this these paraproteins known as Bence-Jones proteins, and that's what we're detecting in the serum assay. And so the serum free light chain assay can be normal in a certain amount of patients with multiple myeloma, and an SPEP with immunofixation with a serum-free light chain assay really increases the sensitivity of a diagnosis of multiple myeloma by over 99% compared to an SPEP with immunofixation alone. So if you have the ability and facility to add on a free light chain assay, I'd highly recommend it, especially for patients that are over 40 years of age, that you are highly suspicious for having an underlying malignant bone tumor, of which a plasma cell dyscrasia like multiple myeloma remains on the differential. So here is a very good example of a case that really shows the importance of the serum-free light chain assay. So this was a 54-year-old gentleman that presented with left shoulder pain and then had left leg pain and left hip pain as well. And if you look at the quantitative immunoglobulins, you can see that the overall results, the beta-2 microglobulin was within normal range. The immunoglobulin G, A, and M were all essentially within normal range or slightly lower. And the SPEP really showed a normal pattern with mild diffuse decrease in the gamma globulin. So no characteristic M spike, and so non-diagnostic for multiple myeloma. If you looked at the SPEP results now in context of a free light chain assay, this is what we see. So a normal distribution of immunoglobulins, but then when you look at the free lambda light chain level, that was 7.3, and the free kappa light chain level was inordinately high at 1,360, which is almost 10 times the upper limit of normal, leaving a free kappa lambda light chain ratio of 186, which is markedly elevated and highly suggestive of a light chain myeloma. And this patient, had appropriate imaging, and you can see had multifocal lytic lesions involving different parts of the pelvis, and ultimately was diagnosed with multiple myeloma. Here again, this is a patient that essentially was referred to see an orthopedic surgeon, again with left shoulder pain, but then was referred to CB because they really had no clear diagnosis. Again, normal pattern SPAP with mild diffuse increase in gamma globulin. IgG was again slightly lower than the normal range for that reference lab, and the IgA and IgM were also slightly lower than the normal reference range. There was no urine Bence-Jones protein that was seen, and the UPEP was also normal patterned. And so we obtained additional labs, including a free light chain assay, and you can see the free kappa light chain levels were markedly elevated at 364, which was significantly over the upper limit of normal. And if you look at the CT scan, you can see that there was a lesion seen in the left shoulder involving the acromion, which is not necessarily picked up easily on the radiographs. So again, my bottom line aside here is that if you suspect myeloma, meaning any patient over 40 with a lytic appearing lesion, you should not only order the SPEP as a part of the standard workup to assess for myeloma, but you really also want to check a serum-free light chain assay because up to 20% of myelomas can be light chain only myelomas, in which case you will not see the characteristic M spike on the SPEP or UPEP. So once you've kind of helped create a differential diagnosis based on labs, based on imaging, ultimately you need to make a definitive diagnosis, and that really can only occur with histopathological assessment. And so, we know like our patient had likely an underlying malignancy, so we then proceeded to obtain an image-guided biopsy of this soft tissue mass in order to help determine the definitive diagnosis. And so here's a paper that was published by Dr. Mankin. This is one of the seminal papers in orthopedic oncology that looked at alterations in the treatment course for patients who had biopsies that were obtained in a referring institution versus the treating institution. This is a paper that we often reference in our teachings to residents and other orthopedic surgeons because when you suspect a malignant bone tumor, unless you plan your biopsy appropriately, you can have a direct impact on both functional and oncological outcomes for that patient, especially if they have a sarcoma. And so I would like to highlight here in this series of Dr. Mankin's, there was a specific difference in alteration in radiation or chemotherapy treatment in biopsies obtained at a referring institution versus the treating institution. And you can see down here, you can see that those numbers were all statistically significant, meaning there was a direct impact conferred by an inappropriately placed biopsy tract. Ideally, when you do biopsies, you want to ensure that the tract is in line with your definitive surgical resection. And if you're not planning on doing the surgical resection, then oftentimes it's better to allow the treating surgeon to help coordinate and obtain the biopsy because there may be a definitive impact on both oncological and functional outcomes, especially with a biopsy tract that's misplaced. So if you suspect sarcoma and you have access to a surgeon who specializes in sarcoma or a treatment center where they have experience in handling sarcoma, please send the patient there for their biopsy because ultimately that will help ensure that they have appropriate oncological and functional outcomes. That being said, I do want to quickly discuss acquisition of diagnostic tissue in a biopsy because many of you are practicing in resource-limited settings where you may not have access to an orthopedic oncologist who may be able to coordinate and do all of this for you. So I think it's important to kind of go through some of the principles of obtaining a biopsy. So generally speaking, the majority of biopsies that we obtain today are core needle biopsies, and we usually have them done under some form of image guidance, either X-ray, CT, or ultrasound. If you have access to these imaging modalities in your institution, using that to plan and complete your biopsy with a core needle is oftentimes the best approach because it minimizes contamination and it can help preserve limb salvage options for treatment. If you're unable to do that, however, and need to go down the pathway of a traditional incisional biopsy, then make sure to plan that biopsy tract along the surgical incision line. You want to ensure that you're using longitudinal incisions because these are extensile and in the future can be used again for the definitive resection of the tumor. You definitively want to avoid contamination of neurovascular bundles. And what that means is, unlike your traditional orthopedic teaching, you don't want to go through internervous planes. You really do not want to identify and isolate those critical neurovascular structures and potentially contaminate them with tumor in your process of acquiring tissue. So that's you got to be very cognizant of that, and that's a little bit counterintuitive, especially for many orthopedic surgeons who are always taught to respect the neurovascular structures and avoid them as much as possible. Definitely do not want to go through kind of safe plane approaches, if you will, for acquiring your tissue. You want to plan your biopsy tract through a single muscle compartment. This again goes back to my previous point. Contaminate only one compartment so that at time of resection, you can resect that compartment as well. Definitely, you also want to minimize raising skin flaps and subcutaneous flaps because this essentially creates additional potential space. And if the tumor is highly vascular and bleeds, you could see tumor cells into this area, and that can kind of expand the zone of involvement and need additional resection. You want to really maintain meticulous hemostasis and use adjuncts if necessary. Bovie electrocautery, use various fibrin-containing gauze sealants if you have them. Really minimize bleeding as much as possible because bleeding is a harbinger of all evil in orthopedic oncology, as this can lead to increased contamination. If you are going to use a drain, which you generally don't necessarily have to, but if you're going to use a drain for your incisional biopsy, plan to exit the drain in line with your incision and just distal to it, so as the drain tract can also be excised at the time of definitive surgery, and again, you minimize the zone of contamination. So this is a paper that looks at incisional biopsy versus core needle biopsy versus fine needle aspirates. And historically, incisional biopsies have been the gold standard, but this paper from the Malawar group in Washington, D.C. has essentially shown that percutaneous needle biopsy is safe and basically the recommended modality in the diagnosis of musculoskeletal masses. And the main reason for this is that the zone of contamination is drastically minimized. You're talking about a 14 gauge core needle usually, very small, and you can place that biopsy tract in line with your surgical incision, and if you obtain multiple cores, you can really achieve sufficient tissue for definitive histopathological characterization. So more and more here, at least in the United States, we've migrated towards using core needle biopsies. If this is available to you, if you have access to a core needle biopsy needle, then this would be my recommended approach, especially if you have ultrasound or fluoroscopy or X-ray even available to help position and guide the needle placement. This really helps minimize contamination. And the diagnostic yields are excellent. So this was a paper that our group published looking at adjunct diagnostic strategies and improving diagnostic yields and image-guided biopsies of musculoskeletal neoplasms. This was essentially a look at improving yield of these core needle biopsies by performing either point-of-care cytology or fresh frozen assessment of the tissue, not to help determine a diagnosis, but instead to just determine if there is sufficient and adequate tissue for diagnosis or not at the time of biopsy acquisition. As I had alluded to earlier, in the United States, we tend to have a lot of these biopsies done by interventional radiology, and in order to improve the overall process flow through the acquisition of tissue and ensure that we have a diagnostic result. This study essentially showed that doing point-of-care testing, either with touch prep cytology or with fresh frozen at the time of acquisition, was highly cost-effective in helping render tissue that was of diagnostic value and minimize non-diagnostic biopsies. So this is another paper that came out of the Royal College of Surgeons in the United Kingdom, and this was looking at the use of intramedullary reaming in diagnosis for metastatic long bone disease. Historically, this was a way that a lot of orthopedic surgeons, especially general orthopedic surgeons, would acquire tissue when they were stabilizing pathological fractures, secondary metastatic disease, or even impending pathological fractures with prophylactic fixation. And the real issue is that reamings are not really adequate tissue sources. And so more than 45% of reamings sent in this study had a false negative rate, and up to 35% of the samples that were acquired were inadequate for histopathological analysis. And the reason for this is because there's significant crushing artifact from the mechanical reaming process. A lot of the thermal necrosis that's produced with reaming, especially in the isthmic component of the diaphysis, can lead to thermal ablation, if you will, of tumor, and that can significantly reduce the viable tissue available for diagnosis. So if you're going to go down the pathway of obtaining reamings, I would say please do not. Instead, do this. This is essentially what's called a pituitary cup biopsy, but you use a pituitary rongeur, create a small access either through a cortical window or through the window that you're using for your cephalomedullary stabilization device, and essentially grab fragments of tissue from the lesion, because this helps preserve tissue architecture, it decreases crushing artifact, and it certainly helps decrease the necrosis of the tumor that is obtained, so that we can really help use that for appropriate diagnosis, including molecular diagnosis. I think another point to make here is that if you have the ability, always send two separate specimen samples and mark one for decalcification and the other for non-decalcification. And the reason for that is normally bone specimens are set in sulfuric acid or hydrochloric acid to help remove the calcium as much as possible so that the specimens can better cut in the preparation of histological slides. But the process of putting them through decalcification significantly destroys any genetic information contained within the tumor and the nuclear information. So while it's good for morphological interpretation, if you want to do any additional molecular diagnostics, it becomes a very poor sample for that. So in the modern era of precision medicine, especially for metastatic disease, it's very important that you try and send at least two separate samples, one with more bone, the other with less bone, more soft tissue, and mark the one with soft tissue as, quote, do not decalcify, end quote, so that the pathologist knows not to put that in sulfuric acid or hydrochloric acid and help preserve the genetic information. Okay, with all that being said, this is what we ultimately did for our patient. Given the soft tissue mass, we elected to move forward with a percutaneous core needle biopsy with ultrasound guidance. And you can see that the fragments of tissue were set for histopathological characterization. On the right side of the slide, you can see an example of the low power view, which based on that, you can see there are many acinar structures and kind of gland-like components. This is highly characteristic of metastatic carcinoma. And so the standard workup for metastatic carcinoma does include multiple immunohistochemical stains. Here we looked at TTF1, CDX2, and CK7 and CK20. All of these stains basically are cytokeratin stains, and they kind of help distinguish between different types of carcinomas. So this patient had TTF1 positivity with a nuclear pattern, which is very specific for lung adenocarcinoma, but it can also be seen with thyroid and neuroendocrine tumors. CDX2 is usually seen in colorectal cancers, and CKC7 and CK20 are both cytokeratins with CKC7 positivity and CK20 negativity seen in lung acinar adenocarcinomas and some breast carcinomas. So ultimately, based on the pattern of immunohistochemical staining as well as the morphological structures seen on the biopsy, the final pathology diagnosis was a lung adenocarcinoma. And so with that being said, what do we know now? And I just want to point you to this dogma, if you will, for workup and management of malignancies in general. This is obviously a very generic cartoon, and it's meant to kind of describe kind of a 10,000-foot view of cancer in general. But as we know, cancer is now very, very specific, and there are a lot of nuances to a lot of this, especially based on histology of the underlying tumor. But nevertheless, I think for something that you should all remember, that the steps and sequence in the process involves first establishing a diagnosis, then staging, and then treating. And you have to do that in that order. You cannot skip from diagnosis state to treatment without staging, and you certainly cannot stage before you diagnose. And I think it's important to help minimize complications to really follow this pattern and ensure you do this in a stepwise fashion to ensure that your patients have the best and optimized outcome. So in terms of staging, now that we've established the diagnosis, what did we do for staging? So just remember that the purpose of staging studies is to really help establish the local and the systemic extent of disease. In many cancers, this has a direct impact on treatment, and localized malignancies are often treated very differently, or at least in a different order of modalities than are widely metastatic malignancies. So stage of the disease, meaning is it localized, is it regional metastasis or distant metastasis, also has a direct impact on expected survival and oncological outcomes. So usually for local staging, what we're looking at is staging within the bone itself. And typically we use an MRI scan with and without contrast of the entire involved compartment. And what that means is for a femoral lesion, you really want to get a full thigh MRI scan. For a tibial lesion, you want to look for a lower leg MRI scan. The reason we do this, especially for primary bone malignancies, is to assess for skip metastasis, because that can have a direct impact on your resection length and your reconstruction. And so, for cases where you have metastatic carcinoma, it doesn't matter as much unless you're using the advanced imaging studies to help direct treatment in one way or the other. For systemic staging, typically the options are vast, but for most secondary malignancies to bone, we either get a CT chest abdomen pelvis or get a PET CT. And the PET CT can be obtained either a whole body PET, which goes from skull base to toes, or a more standard PET, which goes from skull base to the mid thighs. Generally speaking, for most of these metastatic malignancies, I try to get the PET scan at least through the knee so that we have adequate imaging of the femur, which is one of the most common long bones that are involved with metastatic disease. The agent that's used for this scintigraphy varies based on histology. So 18-FDG is the most common agent that we use, but PSMA and 68-gallium dotatate is also used, the latter in the case of neuroendocrine malignancies. As I mentioned, for primary bone malignancies, the staging also involves skeletal staging, and that's usually by way of a technetium-99m bone scan to look for a polyostotic polyostotic process. But neuroscintigraphy techniques are also being increasingly used, like the PET scan, depending on the type of histology that we're contending with. For primary bone marrow malignancies like lymphoma and plasma cell dyscrasia, you still need a whole body CT or a whole body PET CT for staging because a lot of these lesions do present with acral lesions, meaning beyond the elbows, distal to the elbows or distal to the knees, and that becomes important in terms of global characterization and staging for those specific conditions. So what happened to our patient? Because she had metastatic adenocarcinoma of the lung, which does have a predisposition for acral metastasis, she ultimately underwent a whole body PET CT. And again, as I mentioned, whole body PET CTs are important for patients with lung cancer, renal cell cancer, melanoma, as well as the primary bone marrow malignancies like lymphoma and multiple myeloma. Again, because there's an inherent predilection for these lesions to also occur beyond or distal to the knee and elbow. Patients diagnosed with stage 4 disease, ultimately in our case, because she had bone metastasis, and because of the significant discomfort and pain that she was having from this mass, and the potential imminent pathological fracture in the tibia, because both her medial and posterior cortices were largely eroded through, we did offer her surgical intervention. So what did we ultimately end up doing? We ended up treating the site of metastasis with the goal of addressing her pain, trying to maintain skeletal integrity as much as possible. Especially in patients that have impending pathological fractures through a lytic lesion, you want to try and minimize their time that they're off of systemic treatment, because at the end of the day, systemic treatment is what is saving these people's lives. And so pathological fractures and associated bed-boundedness that can come from that decreases their performance status, which can limit their access to systemic therapy. And as a result, you want to try and treat these lesions preemptively or prophylactically as much as possible to, again, minimize their downtime, if you will, and ensure that they can get systemic therapy right away. You want to ensure that whatever construct that you're using for reconstruction or treatment really outlives the patient in any way. Always overshoot the survival estimates. And remember that modern day systemic therapy, including targeted therapy and immunotherapy, have really revolutionized the care of patients with mildly metastatic disease. And so these patients are living a lot longer than they were even a few years ago. And so you can't just assume that they're going to have a 6 or 10 month survival, and you want to ensure that you have a construct that really outlasts that. And you want to anticipate complications. So try and address the complications from the get-go, and try and prevent them from happening, because again, complications prevent patients from being on systemic treatment, and the longer they're on systemic treatment, poorer survival they overall endure. Lastly, my point here at the bottom is that the construct should allow for immediate weight bearing. As one of my mentors, Dr. Raskin, used to say, if you cannot write for a weight bearing is tolerated order in the PACU for a patient with metastatic disease, you have done them injustice. And so I think that's very true. You want to get them mobilizing right away, so ensure that your construct allows them to weight bear right away. So with that being said, here are some procedural photographs from the case that we did. As you can see, this is a medial exposure. There's complete erosion and loss of the medial cortex of the tibia. On the bottom end here, you can actually see that's actually the distal end of the tendon of the soleus. And you can see that the posterior cortex has also been completely eroded through. That's the saphenous nerve that we have tagged and mobilized in order to prevent painful neuroma formation. So this is the tumor after it was resected. Again, somewhat gelatinous, but still maintaining form. Large soft tissue component. And so, like I said, we want to write for an order that allows for immediate weight bearing. So we reconstructed the bone defect with PMMA cement, and then placed a long plate to bypass the segment of diseased bone and prophylactically stabilize the tibia. So this is what the final construct looks like. As you can see, the cement is replacing the area where tumor was previously destroying bone, and we have fixation not only through the cement, but also distal and proximal to it to ensure adequate stability in the bone. So this patient is now approximately 2 years out from surgery. She's ambulating well. She's not using any assistive devices, really has no pain in her lower leg. And so a massive success from a functional standpoint. And fortunately, from a cancer standpoint as well, she's doing very well because she had EGFR positive lung adenocarcinoma, and this has been responding well to targeted therapy. Historically, even 5-6 years ago, patients with metastatic lung adenocarcinoma perhaps had a 6-month or less survival with widely metastatic disease. And you can see that this patient is now 2 years out and still doing very, very well thanks to the advent of targeted therapy agents. So again, highlighting the importance of ensuring that the construct outlives the patient. So I will end my talk here. We'll just quickly summarize the main findings from our presentation. Remember that bone lesions fall into 2 general categories, benign and malignant. The evaluation of a new lesion really involves both clinical and radiographic evaluation. Start with a thorough history and physical examination because almost nothing can replace that. And then get x-rays because orthogonal view x-rays, so AP and lateral most typically, can really help determine many factors of the lesion that can help narrow your differential diagnosis. The radiographic interpretation of bone lesions should follow a systematic algorithm, much like what we just discussed. And you should really consider age, location of the lesion, the margin, the matrix production, and the presence or absence of a periosteal reaction in helping narrow down your differential. The majority of these bone lesions are benign, as I mentioned, almost 100-fold more common than malignant lesions, but you need to maintain a high index of suspicion, especially in specific scenarios where there are red flag findings that are suggestive of a malignant lesion. And more importantly, and most importantly, I would say, whenever in doubt, if you have any concern or question, please feel free to reach out to your neighborhood orthopedic oncologist. I will leave my contact information here as well. You're always welcome to contact me with any questions, especially if you need assistance with workup or treatment of any of these tumors that you might see. So here's my contact information, both email as well as my cell phone. Please feel free to reach out. And a special thanks to my MSK Oncology group at the Leahy Clinic. We can't do this alone almost ever. And so I'm very thankful to my partners in plastic surgery, vascular surgery, and microvascular surgery as well, who help coordinate the care and help take care of a lot of these patients, as well as my colleagues in radiation oncology and medical oncology. So here are some references. You're welcome to look through these at your own pace, and we will send out some of these as well with the webinar link. Thank you very much once again, and I hope all of you have a wonderful day ahead and that you really learned something from this talk today. Again, if there are any questions, feel free to reach out to me. Thanks very much.